My name is Ashraf. I'm going to present a couple of cases in which some of the decision-making may have been questionable, so hopefully you'll all enjoy. So we'll be focusing on distal tibia fractures. So this first case, similar to Mark's first patient, was a 34-year-old woman who was transferred after she had presented initially to an outside hospital. Was found to have a right leg deformity after jumping onto the BART track. So the BART is the rail system here in the Bay Area. She was splinted and transferred over, more for social reasons. But when you talk to her, she was examinable. Pain it was just an isolated injury. She had no numbness or paresthesias. Her social history is notable for active fentanyl and methamphetamine use. She's homeless here in the city, but she has some family support several hours away who live, 4 hours upstate. Her exam, she was neurovascular. Vital signs were stable. Again, the rest of her tertiary was fine. Notable ankle deformity, pretty swollen at the level of the ankle. This was a closed injury with no visible wounds. She was she was neurovascularly intact. And so here are the injury AP and lateral, demonstrating a comminuted distal tibia fracture with an extension into the plafond. And a pretty transverse fibular fracture, so essentially a valgus type pilon fracture, C3 type injury. So closed. Yeah, closed, but with a lot of swelling.
All right, so closed distal tibia, social issues, looks pretty healthy bone-wise. Anything of concern, Steve? Dr. Olson, anything you see there, the history, does anything bother you about the findings so far that's going to change your thinking about initial management?
I still want to get her realigned. Obviously, I want to examine her and look at her vascular question, department, and all those things we talked about.
Okay.
But I really want to get this realigned, whether it's in a splint or optimally even in a fracture.
Actually, go back. Sorry. I just want to point out what scares me when I look at that is how far the fibula is down on the talus, because that's kind of somewhat my keystone, but with those ligaments are all gone.
Yep.
That makes your life much tougher.
Yep.
Okay. But I think in general, nothing special. This patient, we try to get this patient to the operating room as soon as possible.
Yep.
Reduce them in the emergency department, splints. For those of you who don't have a trauma room, the next day or midnight, after the vascular people get all their cases done. For us to have a trauma room, we try to get them on the schedule, and we would be thinking external fixture.
So, I disagree with that.
Yeah.
So, I treat these a little bit like open injuries to some degree because I've never had difficulty, I shouldn't say never, but reducing the plafond is not the problem. Getting the fibula out the length is a problem for me. So the night they come in with a bad plafond, I like to take them and put that, I do a spanning X-fix, articulating one pin in the calcaneus, one in the talus, but I plate the fibula if I can, if the skin allows me. And that makes my life so much easier because I have a very hard time getting the fibula.
Are you going to tell the OR supervisor to cancel the spine cases in order to do a closed reduction in the operating room?
No, it's not. Well, it's to some degree. I'll tell her whatever I need to tell her. But my point is that I'm doing this at night usually, so it's after the day already. But
Okay.
I don't want to wait on this because I know I'm going to have to wait on the soft tissue by the amount of comminution there for the plafond, but I don't want to wait on the fibula.
Okay.
So
One of the key points that Dave Shearer made earlier is that if you're going to be the one treating the patient definitively, then it's okay if you plate the fibula, but you don't want to burn the bridge of needing to go posterior lateral. I don't know, we don't have the CT yet, so you don't want to burn a bridge and plate the fibula and that be the wrong
better surgeon than me, so that's, you might be.
That's probably the case.
Probably true.
So Tim, all right, I've got a comment. Yeah. So this, Kyle picked up on this earlier, but I was noticing the same thing, although Kyle noticed how distal the fibula was and the lateral talus. I was noticing how wide that talar fibular space is. I anticipate this is not gonna reduce easily because normally the talus and the fibula are connected together, they're gonna follow each other, but here it's not just the syndesmosis that's disrupted, probably the talar fibula is disrupted. Yeah. But the point I was getting at is this is gonna not be very stable even in an external fixator.
This doesn't look right.
Yeah, you know, because you can get the fibula, but the foot's still gonna be going all over the place.
Right.
And so what vector do you want to do, medial fixator and anterior fixator? And then you've got an unreliable patient.
Yes.
Maybe a patient where I'm going to put a retrograde stem and pin up through the calcaneus, the talus, and into the tibia to give that some more stability. I don't think that external fixator is going to hold this very well.
This patient's pretty unreliable, so if you put the silver spike up
They won't wait there either.
then they're gonna disappear and it's gonna break.
That's true.
All right, back to
We'll
Nate.
get infected.
Take us through your thinking
All
and
right.
what we have here.
Yeah, so we got her provisionally splinted. And again,
What I just said.
yeah.
Look how well that fibula lines up just with a splint.
Yeah, I was just saying, forget what I just said.
And so took her. So the next step. So I think we all agree that this is going to be a stage procedure, regardless of what we end up doing with the swelling. So, in terms of further imaging, this patient's eventually going to get a CT. My preference is to get a CT after an external fixator is placed, because at least the pieces will be closer together to where their home is, so I can plan my incisions. Got her to, so this is our intraoperative fluoro with the external fixator. So I think the fibula's length is okay, Dr. Dixon. But again, the articular block, it's, I can't make sense of what's happening with regards to the joint level. The next step, so this was sort of her alignment. The main thing here that stands out to me is just the A to P dimension of the tibial plafond. It's incredibly wide, so it's not behaving like most of our pilon fractures. And this is, sort of some representative shots. So the image on the left is just looking at the 3D from the front. From the back, it doesn't look notable, but on the coronal split, you can see that there is a flipped articular segment sort of within the metaphysis, so that squarish block, so that's a piece of joint that just flipped up, which sort of gives us an indication of where the talus was at the time of this injury. So I think this is a good, and then I think I have an axial. Okay, no, so after third day after the external fixator, she's starting to have some acute withdrawal symptoms. But fortunately, she is a little directable. She's open to talking to our addiction care team. She's agreeable to starting methadone. And so she's, showing some signs that, we have a whole spectrum of patients with substance abuse. Some are, feel really strongly about continuing their hobbies, but she seemed like she was sort of amenable to change. But going back here, and here's the representative axial cut where you can see where that anterior fracture line comes up. So the swelling improves by post-op day 12, where we consider doing something. And so sort of with this set of images, would want to see sort of what folks would plan, what sort of approaches they would take. So pretty bad tibia fracture, pretty simple fibula fracture, and a lot of joint work would need to be done to get this sort of looking like an ankle again.
So if I could just comment on this axial segment there, that is like a great example of like one of the worst plafons. You usually get, I can't tell, but it looks like there's two anterior pieces. There's like the medial malleolus piece, two posterior pieces, and then the central. I'm just not used to the central piece being under the knee.
Yeah.
So Steve, tell us about your decision-making for incisions with these complicated plafond fractures.
Well, I think the first thing I think about is where I'm gonna make my fibular incision. And looking at this, I probably would make it a little bit posterior lateral. So that way
why it's wide now, right?
Yes.
Because all of that posterior piece is supposed to be up around the fibula,
Yep.
and it's keeping it from that way.
So making sure it's split by the fibula and the axial.
Right, so that, all of that thing that's posterior is supposed to be over the fibula.
Steve, do you think fixing the fibula in this case really helps you much?
Well, I don't know how much it's gonna help me. I think.
I mean, other than making you feel good like you fixed the easy part.
No, from a point of view of, what we don't have here is the contralateral images.
The contralateral looks fine.
But the point is, if I have a good landmark on the fibula
Yeah.
as to where the
Yeah.
plafond should be,
Yeah.
then I
Remember,
can
this
use
is
the
a,
same landmark.
look at the patient though. The patient's not a 28-year-old elite athlete, you know, normal person.
Well, why not just?
And so
What
you
the hell?
gotta work on tissue, so you can't make 4 incisions here.
But Trent, what this does show me, which is very helpful, is I now have a piece that's going to give me, to some degree, where the plafond is. So that anterolateral piece is still attached to the fibula. The posterior, that's all gone. But that's going to be my key to reduce the whole plafond.
The anterolateral, so you need an
Yeah.
anterolateral approach to the
So I'm
plafond.
saying that mine would be an anterior anyway, along the tibialis anterior, but my point is that is your piece that's gonna be somewhat of my keystone for reducing the plafond.
Show me what you're talking about that.
Can you guess your point?
Is there a laser on this guy?
I think I know what you're talking about.
Anterolateral piece, so, yeah, just point. No, no.
No,
well,
no,
On that,
on the
yeah,
3D.
right there, that's what's, that's why getting the fibula perfectly rotated and out the length is so important.
Okay. So it's a pilon fracture. It's a C-type injury, meaning the entire articular block is not attached. And so the question, the way I try to think about this is sort of whether I'm going to try to turn this into a B-type fracture or into an A-type fracture, right? So am I going to build a block and then attach that block to the shaft, or can I extend the shaft down and sort of keep adding pieces to it? And this was one where it was really hard to make that decision. I was really perseverating over how I'm going to control this posterior piece, especially in light of the comminution, because I think in order to get this plate and lined up, ideally you'd want to do a posterior-based approach, but that was something I didn't really want to consider given her risk factors and the wound complications. So I went in planning for an anterolateral approach because I knew I was going to do most of my work at the joint by opening up this fracture line, and the anterolateral approach would put me down there. I was like, I'm going to not make a decision regarding the fibula until I see how the case is progressing. So in terms of the operative course, I started with the anterolateral approach. Even though this was a closed injury, it looks like there's bone missing, and then started just sort of working my way down. So just trying to make, attach little pieces to start getting a sense of length and alignment because she had some discrete metaphyseal pieces. But then this is where I really started to struggle. Again, trying to get some length and alignment, I was like, this just kept going on. So I was like, it's a pretty transverse fracture. Through the anterolateral approach, I was able to get a clamp on the fibula there. And because it was pretty transverse, we just put we had our length on the fibula, so put an intermedullary screw up. And then kept trying to get that piece. Of note, that centrally impacted piece, when we flipped it down, it was completely denuded of cartilage. And so, we just kept pressing on, but then the more I thought about it with an area, with it being denuded of cartilage, and I was having a really tough time trying to grab this piece to bring it forward. I could never get the A to P dimension to look somewhat right or to match the concavity of the plateau. I was like, I need to go posterior to address this, but I really didn't want to,
How big was how much of the articulation?
Yeah, it was probably like 1.5 centimeters by a centimeter and a half. Yeah, by a centimeter. It was centrally located.
So now you're struggling, and you have a really unreliable patient with articular surface injury. Does that change your intraoperative thinking about what kind of fixation you might choose?
Well, it changed my, yeah.
I mean, I try to do
I mean, you
that.
treat fat people.
What?
You treat fat people.
We have a lot of fat people. Yeah, we have a lot of fat people.
So what do you do with fat people?
Depends on, their age and so forth. I mean, on this, I would try to get the best possible reduction. I think an anterolateral approach is the right answer. I don't know if the fibula really helps you here.
Yep.
But I think a posterior medial approach, which is
Mhm.
least favorite, to get, if you go back to the 3D CT,
Yeah.
you gotta have something to key off of in the back too, and there's that comminution more, that, you wanna avoid the comminution posterior laterally, but you've got a little bit of a key there posterior medial.
Yep.
So I might go anterior lateral and posterior medial, but then what position is the patient gonna be in?
Yeah,
On the operating table.
Right.
Yeah.
Okay.
All right, so,
Painful.
yeah.
Yeah, this is hard.
So with the fair amount of denuded cartilage, and I didn't feel I could achieve an acceptable reduction without a separate posterior approach. And I was really hesitant against doing so given the risk factors. So I actually just said, I'm just going to restore as much of the metaphysis, fill in as much of that gap with bone graft. And that's a separate question. And I would admit that there's not evidence behind that. And return later for consideration of a TTC nail. I had not specifically talked to her about it.
Yeah.
Yeah, no, I mean, I've done a lot more TTC nails since
Yeah.
I've been in Tennessee in the last 3 years. Because
Yeah.
old people, shitty bone, they're overweight, and trying to reconstruct this makes
Yeah.
no sense. And you can weight bear a hind foot nail immediately.
Yeah.
Small incision, you don't make any, it's pretty easy.
Yeah.
Pain in the ass with those is that the screws going through the calf, you're upside down.
Yeah.
So we do them in a sort of a lateral type position where
Yeah.
you're not
Yeah.
laying on the floor like a car mechanic looking up at the.
Yeah, and because I, without the foresight, had not talked to her explicitly about it beforehand, I had to have a discussion with the patient. And so this is how she left the OR. And the AP looks, it looks better than it actually is in the wound, and that's something as a surgeon, But again, the lateral, there's, that's not a meaningful reduction. I'm sorry? I did not go posterior. I just, yeah. And this is just with all the bone graft in there, just because it's all I know how to do from the spine side. And this is what she ended up with. She followed up once a month, and then I've never seen her since. So I can't give you.
There's nothing wrong with that. That's probably a good result for her.
Yeah. So.
No, I congratulate you. I think that's really good. I mean, I think you're in there a couple of hours, and now you have denuded, comminuted segments that you're not going to get much of the joint. I applaud you for making the decision to enough's enough, and then come back and look for different options. I don't think any of us would have consented her for a nail, so I don't think.
Well, you were heading in that direction initially with the pin up the. It's just a much bigger pin. Yeah. Yeah. Okay.
No, I think any discussion, criticism about that?
I think that's
Right there.
I think that's a good call.
Go back, go one forward. See,
There was maybe another one here.
what I saw in the lateral, it looks like that is reduced to that anterior piece that little piece that's still part of the fibula. So, yeah, that piece, go to your more anterior, yeah, that's it. So that's kind of your keystone. And so what it seems like is that posterior lateral piece, you just never could get.
I couldn't control it to bring it forward.
To get it forward.
Yeah.
And I'm not sure what I would have done there, but you're close there because your talus is reduced to it. You
Yeah.
just got to get that piece in.
Yeah.
Yeah, but look at the mismatch between the posterior cortex of the distal tibia and the
This is
posterior.
probably right.
That's what I'm saying.
Yeah,
That's
that's-
right.
but-
And here's the gap.
Right.
So he just could not get
You
this.
couldn't get that.
I
back
couldn't.
where-
I couldn't get it down, and
Look
and
at the posterior cortex of the tibia proximally, and then draw a line down there. It doesn't even come close to matching up with the posterior malleolus.
This needs to be down here.
Yeah, exactly.
And I mean, I would have loved to have been there and struggled with you, but I just think you were close.
Yeah.
Yeah, and so there, like, I at least was able to get the anteriors where this posterior cortex sort of lined up, but this did not look like a contour that matched the talus. And I was like, and I couldn't, you know, and this probably a rotational thing. Yeah, so that's what she ended up with.
All right, I like it. Any other discussion?
It makes me just, you know, puke, as you said, on the way up. So I disagree with Ken, but I'm not sure what else to do.
Yeah, yeah.
I mean, that posterior piece is still hanging out the back.
Did you get any follow-up on her?
She came back at 4 weeks, and I never saw her again. Yeah, yeah, she was up in Wairika. Yeah. Well, she was with her family at the time. She came down with her brother, and yeah. This one's a little bit more straightforward of a discussion. So, 42-year-old, a year into the pandemic, had a twisting injury to the ankle, no pain elsewhere, no significant social issues. Again, the physical exam is, there's nothing tricky in here, pretty straightforward. And this is her injury here. So a distal sort of spirally shaft fracture with an associated fibula fracture and a little bit of valgus, some fibular shortening. Just gonna, I think there was with this pattern where you sort of have that spiral nature, I just wanted to know if there was any extension into the joint. There was no extension into the joint. So the question is with this, what folks' plans are, namely, is this something that you would plate or something that you would nail?
Yeah. Steve, what you thinking, plate versus nail or combination nail plate? What about the fibula? What did the fibula look like? Pretty comminuted.
There's comminuted and short.
Okay, comminuted short fibula. The skin's okay.
Skin's okay.
What kind of comorbidities?
No tobacco use. She's housed. She's employed. Occasional edible like THC, cannabis use. But overall, it seems like a pretty reliable person. Has regular follow-up in the medical chart.
So if I chose to nail it, I think you could nail the tibia. If I chose to nail the tibia, this is one where I would plate the fibula.
Okay.
Because I think it gives you length rotation, helps you reduce the tibia, makes the nailing easier if you choose to do that. You could plate it, but ideally, plate tibia on the lateral side, then you're looking at how do I get there, put the fibula and the tibia comfortably. So I might choose to plate the fibula and nail the tibia.
Yeah.
Who likes a nail? Anybody like a nail? Who likes to plate?
I perk plate the tibia.
Okay, so per plate.
Get it out of the
tibia,
way.
Good choice. And is that extreme nailing? No, it's a pretty, it's.
Yeah. Yeah. At this point, I would say it's yeah.
Dr. Olson suggested that the fibula needs to be treated first to give you some length and rotation. Probably a little easier nailing with the stable fibula. I
Yep.
kind of like that. So I think I'd be in favor of initial stabilization of the fibula.
Fibula. Yeah. The swelling's amenable to it.
Yeah.
Yeah, I ended up going I ended up plating the tibia. And I don't really have a good rationale why. I think the concern with plating the tibia is what type of plate you're going to use, right? So the options are an anterolateral plate or a medial plate. A medial plate I usually use for more of a varus tibia. This one's more valgus. So I kind of wanted more of an anterolateral plate, but I didn't want the incision to be close to where my fibula plate would be. So for me, I ended up doing a distal tibia plate through an anteromedial approach, sort of a limited one-ish, and then a distal fibula plate through a posterolateral approach. The reduction was pretty straightforward for the tibia and the fibula. I had a small provisional plate there to get that spike, but then removed it later because my intention was to have more of a bridging construct for the tibial shaft fracture. Yeah. But I think, I really do think that this is one that either option would have been, amenable for. Yeah.
Anybody consider posterior plate? Go back. Is that posterior cortex? Can you get a read back here?
Yeah, I think if you went high enough, I think it's Yeah, I think you would have been able to.
You know, traumatologists love to
Yeah.
work in the back.
Yeah. Yeah. You know, I've always, you know, like for posterior malfractures, I absolutely love going prone and posterior, but I've actually never really done that, like a posterior shaft fracture.
Right. I haven't either, but it just,
Yeah,
it kind of made sense.
but I don't know why not.
Kind of looking at that, like, gosh, those cortex are just saying, line me up and put some kind of a device on.
Yeah.
And then you know, if you had a fairly good-sized plate,
Yeah.
you may just, you know, may do the fibula one, may have one incision posteriorly.
Yeah. No,
That's good, it went on the heel.
yeah, it went on the heel, but then at 12 months, sorry for the lowercase p, but she had some residual CRPS and
You probably like that.
symptoms, and I wonder if I had nailed it, whether that would have been the case or not.
Yeah, I would have plated the fibula and just perked the medial side with a long plate. And not, because you have to make a fairly,
It's a long incision for the anteromedial.
yeah,
Yeah.
I don't,
But
Yeah. Well, that's good, you got a deal.
yeah, but I do wonder, you know, like, I mean, I still don't quite understand complex regional pain syndrome, but she definitely had like the skin changes and that sort of thing that were symptomatic, you know. It seems like it's probably related to the insult that we do with surgery, so maybe if I had nailed it, she wouldn't have developed that, but I actually can't say that with certainty.
Well, then she would have had mediating for the rest of her life.
Yeah.
You get small fiber disease with all the fibrosis from this bleeding and stuff.
Yeah. Yeah.
Yeah, apparently there's sympathetic and non-sympathetic small fiber disease.
Yeah.
in
Yeah.
CRPS.
I'd say that, I mean, you could disagree, but I think the trend is more towards nailing extra-articular fractures.
I think so.
Yeah.
I think so. And I think with the semi-extended positions, the different options that are available to us. I think this was from my like first or second year in. I think at this point, like today, I would have nailed it. Yeah. Yeah. All right. Thank you.
Thank you.